Welcome to Second Opinion, integrating novel approaches into the management of non-muscle invasive and muscle-invasive bladder cancer. This is medical oncologist Dr. Neil Love. On February 26 at the 2026 GU Cancer Symposium in San Francisco, we held a CME meeting moderated by Dr. Terence Friedlander from the Helen Diller Family Comprehensive Cancer Center in San Francisco, and faculty members Dr. Matt Galsky from the Tisch Cancer Institute in New York City, Dr. Andrea Necchi from the IRCCS San Raffaele Hospital in Milan, Italy, and Dr. Shilpa Gupta from the Tulsa Cancer Institute in Cleveland, Ohio. Included in the meeting were a series of pre-recorded video case presentations by Dr. Elizabeth Plimick from the Fox Chase Cancer Center in Philadelphia and Professor Thomas Powles from the Barts Cancer Institute in London, who met with me prior to the meeting. These cases were discussed by the faculty panel, beginning with Dr. Plimick.
72-year-old man, active lifestyle, healthy, some hyperlipidemia, exercised regularly, had non-muscle invasive bladder cancer diagnosed several years prior. He had been through induction BCG and maintenance, and subsequent to that, gemcitabine docetaxel and also nadofaragine. His pathology at presentation was high-risk T1 non-muscle invasive bladder cancer, and after each of these treatments, he had maybe one or two TURBTs that looked clear, only to have a recurrence of, again, high-grade non-muscle invasive bladder cancer afterwards. He was referred to my clinic by one of my urology colleagues to consider pembrolizumab as treatment for his non-muscle invasive bladder cancer after these 3 lines of therapy. My patient asked a lot of questions. His main goal was to avoid cystectomy. He really valued his sexual function, and that can obviously, with cystoprostatectomy, take a hit with that intervention. But he did not want to do the pembrolizumab, mostly out of the concern for side effects, but also, I think, because it wouldn't give him high chances of a durable response. This particular patient that I'm presenting, I saw a year and a half ago, and that was before the TAR-200 device was available. Obviously, there are a lot of strengths to that treatment. I think here we like it. It's off the shelf. It's easy to place. And it's intravesical. It's not systemic, so we avoid those toxicities. It wasn't an option for this patient just because it wasn't available. But I'm curious now that it is, how do you layer the TAR-200 into your treatment recommendations for patients with non-muscle invasive bladder cancer?
Great. So just to summarize, as a patient of Dr. Plimick's who had non-muscle invasive bladder cancer, has had BCG, has had nadofaragine furadinivec, as well as gemcitabine and docetaxel. So had a lot of therapy in the bladder. And the question is, if they're fearful of a PD-1 inhibitor, we do have data from Keynote 057 suggesting that pembrolizumab has value in BCG-resistant disease. But this patient doesn't really want PD-1 and has talked about TAR-200. I wonder, Dr. Necchi, how would you counsel this patient? What would you tell them about TAR-200?
Yeah. Great point. So it's one of the most difficult to treat cases that we may encounter in our practice. So, first of all, I would point to the fact that radical cystectomy is the most effective standard of care, and is the only standard of care in most of the geographical areas, like European Union and most of the extra US countries. So we have to counsel very, very carefully the patient and inform the patient to the benefits, the potential benefits in terms of possibility to be cured related to cystectomy. Second, there is a global message that is arising from the multiple trials that are being conducted, and that I will summarize later on today. That is pointing to the efficacy of intravesical therapies in this patient population rather than systemic therapy. So, with regards to the activity reported to as CR rates and preliminary long-term duration of CR rates, there is clearly a trend that clearly favors intravesical therapies with TAR-200, cretostimogene, or other newer therapies, newer intravesical therapies that are going from clinical trials to the real world. as compared to systemic therapy, also with the advantage of potentially limiting the side effects with the local symptoms of irritation and nothing more, as compared to the potentially deadly events that may occur with the use of systemic immune therapy, also with the best tolerated drug that we can use today. So these are the 2 points. First, we have to assure that the patients really want to avoid, and the reason why the patient want to avoid cystectomy, which is the standard of care, and then pointing to the intravesical therapies as the primary choice in these particular patients when it comes to try the further therapies that they may be approved or not approved in your particular country.
Great, thank you for that. Dr. Gupta, we have a lot of these therapies now available, right? There's viral therapy, there's chemotherapy, there's sort of other novel targets. So, we don't have head-to-head data, but how would you counsel a patient? What would you say to them if you had, for example, many of these therapies available? How do you counsel them? How do you think about that?
Yeah, so as you know, this is primarily a urologic disease, but we are seeing more and more of these patients who come and talk to us. So I think none of these trials, we can't compare trial to trial, and there's no sequencing data that we have. So I think it all depends on how much can a particular patient's bladder take, and I've asked this question to my urology colleagues, and I think it all depends on how friable it is, and can they keep giving more intravesical therapies or rather proceed with cystectomy, like Dr. Necchi said, which is the standard. But I think it's great to have these options so that patients can get exposed to these agents in sequence, but we don't know what that right sequence is yet.
Right. It's really a balance of preserving the bladder, keeping that intact, because a cystectomy is a morbid procedure. As beneficial as it is, it can also be very challenging from so many levels. Dr. Galsky, what do you think about the role of PD-1? This patient's fearful of the side effects of PD-1. Are there things that the patient might not be kind of thinking about in terms of disease progression or risks for side effects from more localized therapy? How do you talk to a patient about that?
So I think it's important to recognize that none of the treatments that are being discussed have been studied in a patient like this who's received multiple lines of prior treatment intravesically and has high-grade T1 disease. I'm really worried about this patient. I think that declining cystectomy is sometimes based on how the procedure is framed and the balance of risk versus benefit and what the risk of disease is in that patient. So I would reinforce the risk for metastatic recurrence in a patient like this. I think systemic pembrolizumab, because of that, is not a horrible idea, but again, it hasn't been studied in someone who's received multiple lines of intravesical therapy. TAR-200 in a patient who's received prior intravesical gemcitabine, I don't know about the effectiveness of that. There certainly could be a PK advantage to the intravesical delivery system, but at the end of the day, it's the same drug. I would say that if this patient declined everything else, I might be leaning toward BCG and NII in this patient. We know that BCG retreatment has a role, even in the absence of NAI, and so from a non-cross-resistant regimen standpoint, in a patient who is really declining cystectomy, that would probably be the regimen that I would favor in the absence of data.
Okay, thank you. And so we talked about TAR-200, and I know, Dr. Necchi, you're going to talk much more about this, and actually tomorrow you're going to be presenting prospective data about TAR-200. So for folks who maybe aren't that familiar with it, how do you describe this? You put many patients on trial. What do you tell them this is? Is this just chemotherapy, or is it something more?
Yeah, the drug is not new. It's new the way we deliver the drug into the bladder. TAR-200 is now called gemcitabine intravesical system. You will now see that it is referred to as GEM-IDRS, gemcitabine intravesical system. Is a way of delivering gemcitabine into the bladder through a silicone tube that release in a continuous way the gemcitabine drug into the bladder. It is put with a catheter in an outpatient procedure, so very, very easy. The patient come in the morning to the clinic, receive the deposition of the drug, and then goes home without any major side effects for the majority of the cases. So it's a very, very simple procedure, and the removal of the drug usually occurs every 3 weeks. So it could be pursued in a long-term fashion. So it's a very easy procedure, but also requires, in any case, a procedure, a surgical, an endoscopic procedure, a catheterization, an hospital procedure to be put. So it's not something that could be done at home, at least for the moment. But anyway, the safety profile and the way it is put into and then removed and substituted into the bladder is very simple. And what is making the key actually for the drug is the continuous exposure of the tumor to the drug as compared to the peak of the concentration of the drug that is usually very, very short-living when putting the drug as an instillation into the bladder.
Yeah, so it's a very long-lasting, durable benefit or exposure to drug as opposed to just a one-time. Let me ask you, Dr. Necchi, what would you ultimately recommend? Dr. Plimick didn't have access to TAR-200. You know, it's now FDA approved for CIS patients with CIS refractory to BCG. Would you recommend TAR-200 in this case, or would you go with something else?
Well, with all the limitations that Matt has raised. Limitation of the data in this particular case, in this particular situation, based on the fact that the patient still is against radical cystectomy, I would use TAR-200 as an option for the patient.
All right, great to hear. Okay, and now we're going to hear from Dr. Pols.
Professor Pals has for your consideration a very fit man in his late 70s with CIS.
It's a new presentation of non-muscle invasive bladder cancer. The classic treatment would be BCG induction and maintenance. And the question is whether now, because of these two positive trials, CREST and POTOMAC, and of course the one negative trial with the atezolizumab, the ALBAN trial, whether this is the right treatment for this individual. Should it be BCG alone, induction and maintenance, or should we add in an immune checkpoint inhibitor? And I had a chat with this guy. He was prepared to buy drugs himself and go because they're not currently licensed. He said to me, look, Tom, what would you do with unlimited resource and in this setting? And you know what, Neil, the discussion's really complicated. I said to him, look, I probably wouldn't take the risk. I would do BCG induction and maintenance. I'd keep a close eye on things and we'll see where we go. And if the cancer was to come back, we can then have a discussion about further treatment options. And then he said to me, well, hold on a second. I read in one of the papers that CIS patients do even better with this. And I came back to him and said, well, there is in one of the studies, but in the other study, the opposite is true. And so I just said to him, if you are older and you are unable to have a cystectomy, or if you said to me, Tom, I'm not having a cystectomy under any circumstances, and I'll do anything to avoid that, that might be a slightly different discussion. But at the moment, I would stay on the current pathway.
Okay, so just to review, this is a patient with frontline NMIBC with CIS who has unlimited resources and can get any drug they want. And so what they want to know is, should he be adding a PD-1 inhibitor to his frontline BCG, assuming it's available? And so the question is that the right thing to do? And I guess, Dr. Gupta, how would you counsel the patient if they had this option? And I've sort of given my opinion in my talk, but what do you think?
I think, if we had access to this drug, we have to, in due diligence, discuss the full data, right? 2 years of immunotherapy, it did have substantial toxicity in this study. But like Dr. Paul said, it did show in this particular study that patients with CIS derive more benefit. And if we look at other studies, it didn't show that. So I think we also know that the control arm did very well in this study. BCG was very good. So I think if we had this available and patient was willing to take the risk of the long-term toxicities with 2 years of checkpoint inhibitor in this very early stage, then that's the informed decision we have to make for the patient.
And Dr. Galsky, when we look at the data, the delta between the two arms for both trials for EFS was between about 6 or 8%. So we're giving a lot of drug to people for a modest benefit, to prevent 8% of patients from having a relapse. Is that compelling in your view? And we don't have overall survival data yet. We may never have overall survival data. How do you interpret that?
So I think it depends on what the events are. And event-free survival is a composite endpoint, and so those events mean different things in different contexts. I would not expect to see a survival benefit in this clinical disease state. That is not an immediate threat to these patients, but what is an immediate threat is progression that would require more morbid treatments and more life-altering treatments, and preventing that to many patients is worth that trade-off. So I think this is a shared decision. Right now, we really don't have the option. This is not an FDA-approved treatment. None of these are for this particular indication. But I think if they were, then for a patient who's informed and says, I want to do everything to make sure that this is the only treatment I need for this disease ever, I think it's a reasonable trade-off.
Yeah. And then in terms of the side effects, I'll just sort of add, we saw real toxicity with this. And so I think if these drugs become approved, just like using PD-1 inhibitors anywhere else in the field of oncology, we really have to counsel these patients well. These are patients who are having their very first interaction with oncology, with having cancer. They may not really understand the gravity of some of these autoimmune side effects. So that can be pretty significant. I guess, Dr. Necchi, do you think there's an ideal candidate to get PD-L1? Do we have a biomarker that can say, this patient should get PD-L1 with BCG and this patient probably won't benefit? Because we saw, as I mentioned, discordant results in the CIS group, although I think that might be explainable. But how do you interpret that?
Well, not at least at the moment, based on the biology of the disease that may orient us towards a certain decision. In this case, it's fully a patient-driven decision, right? Because we stated that the patient can access to any kind of therapies. So it's a patient decision. One thing that I would put as a safety barrier prior to decide, just as a way of counseling in full the patient that they have to decide. There is also the point of the attrition rate and the way of preventing the patient to receive any kind of systemic therapy, effective systemic therapy later on, in case they develop a relapsing disease or progressing disease. So one thing they should be put into the table when they're in the discussion is the fact that the magnitude of effect that they demonstrated with addition of an immune checkpoint inhibitor towards BCG versus BCG should be counterbalanced with the magnitude of loss of effect they could be affected with in case they experience a disease progression and they could not access, or at that time would be prevented to receive, for example, EV-Pembro later on, or immune checkpoint inhibitor combination therapy later on. So there is a new point, a new argument to make with regards to the sequencing of therapies that starts exactly from this situation, from the BCG naive, a very first diagnosis of bladder cancer.
Right, so it's not only planning for today, it's planning for tomorrow. And if you use your PD-1 agent early in the disease course, what are you going to give later? I don't think we have a lot of data, but I'd love to hear from our panel here. Is there any data that suggests that you can give a PD-1, patient gets resistant, and then give a PD-1 later? My view has always been that we shouldn't be waiting to give PD-1 inhibitors to patients with bladder cancer. The avelumab Javelin Bladder 100 study of avelumab showed us that earlier avelumab associated with significant survival benefit. My view has always been that getting the PD-1 into the veins of the patient is what really matters, getting that in early. And then we saw that in 302, where you see earlier PD-1 was beneficial. EV-302, the frontline study of EV-Pembro. But is that true now in this early phase, in this non-muscle invasive phase? And Dr. Galsky, I guess, how do you think that that's a valid argument? I've heard sort of controversy about that.
Yeah, I mean, I don't know that I would frame it in terms of earlier use is always better, but I would frame it that in any clinical disease state, I never really buy into the argument of saving something for later. Like our goal with any of our treatments is to try and get rid of the disease, short of metastatic disease, where of course that's more challenging. But in all of these disease states, this is curative intent treatment. And so to withhold something for later, why would you not give your best shot up front, right?
Right, but of course the counter argument is against toxicity and other issues. As we're going to, go ahead.
And I think that's a totally legitimate argument. If that's the argument for saving it, that's reasonable. If the argument is that I want to use it later, that doesn't make sense to me, because if the biology is such that you give it now and the disease comes back, then that biology would not have benefited from getting it later.
Later, right. So perhaps there's no magic to giving it later with EV or with another agent. It's like put your best foot forward, but balance that against the toxicity. So I guess, do you think that there is, Dr. Necchi, do you think that there is some value to the PD-1 plus BCG? That's a double immunotherapy. We have TAR-200 plus citrilimab, which is giving chemotherapy with immune therapy. Do you think that there's some synergy or some connection here that makes this a more valuable therapy than giving it with chemotherapy or other agents?
It's difficult to say at the moment because based on the trial data that we have today, we cannot dissect clearly the contribution of systemic therapy over intravesical therapy with regards to the numbers that we have, EFS data, clinical complete response rates, and so. We should definitely wait for the ongoing trials with combining TAR-200 and systemic therapy. We will show you which kind of design are being completed or ongoing. But at the moment, it's very difficult. And based on the data, for example, that we show you in the non-responsive setting with TAR-200 and something else, as compared to TAR-200 monotherapy, it's difficult to position systemic checkpoint inhibition in this patient population.
Right. So maybe there is a difference depending on which agent it's being partnered with. We saw that in the metastatic setting. Actually, Dr. Galsky had a great paper that looked at the difference between cisplatin and carboplatin and the immunologic effects.
Subsequent to the recording of this program, the FDA approved durvalumab in combination with BCG for the treatment of adult patients with BCG-naive, high-risk, non-muscle invasive bladder cancer. The FDA approved pembrolizumab in combination with enfortumab vedotin as neoadjuvant and adjuvant therapy for adults with muscle-invasive bladder cancer undergoing cystectomy. The FDA also approved adjuvant atezolizumab for adult patients with muscle-invasive bladder cancer with MRD-positive ctDNA after cystectomy. Please check out the official prescribing information for more. This concludes our program. Conflict of interest statements for the faculty can be found in the program notes. The use of agents and treatments that are not approved may be discussed, so check out the package inserts for more. Special thanks to the faculty, and thank you for tuning in. This is Dr. Neil Love for Second Opinion, integrating novel approaches into the management of non-muscle invasive and muscle invasive bladder cancer.